Sound check, sound check. Patrick, can you hear me?
Yes, good morning. Is that Dr. Malemela?
That's Jameson.
Okay, thanks. Audio is good and video is good. You can mute the video and audio. Thank you. Sister Lesejo?
I'm available.
Okay, and your video can also be activated. Thanks, just checking. And then also just to check with Segi. Segi, I see that you are logged in and have been assigned the co-host status. Are you with us?
I am Ashraf. Good morning.
Good morning. Great. Thanks, Segi. And then just to double check, Dr. Kuzwayo.
Good morning.
Good morning, Dr. Kuzwayo. Welcome. Just to check, your audio is working. You can hear us?
I can hear you loud and clear.
Great. And once we get to your point, we'll talk you through the steps just to ensure that you share your presentation. My understanding is that Dr. Sitslaho is not with us yet. I don't see him. Okay. So we're about to commence. So thank you everybody for that sound check. Good morning to all the participants of today's webinar. This webinar deals with the management of persons under investigations, that is the PUIs for COVID-19, experiences in different sectors. And today we will deal with the mining sector, the hospital sector, aviation, and local government and municipal levels. So I just need to quickly check if my colleague, yes, Dr. Tanusha Singh is online. Tanusha, a quick sound check with you.
Hi, Ashraf.
Great. So I'm going to hand over to you to start the program. Thank you, Tanusha.
Okay, good morning, everyone. I'm Tanusha Singh, as Ashraf has mentioned. I am the COVID-19 Outbreak Response Team Chair at the NIOH. It gives me a great pleasure to open today's session and to welcome you all on behalf of the National Institute for Occupational Health, a division of the National Health Laboratory Services, and a warm welcome on behalf of Wits Health Consortium. It's really wonderful to see all the participants from across the country and across all the various sectors and industries as well. A very warm welcome to our guest speakers, and thank you for your availability and willingness to share your knowledge and experiences from your various sectors. We are really honored to have you once again, joining the NIOH platform. As Ashraf mentioned, this is a repeat session, but we are looking at different sectors and industries today. All our training sessions are recorded and is available on our website. So if you missed the previous session, do visit the website. To make information even more accessible, we were very fortunate to have received generous funding from the Health and Welfare HWSETA, which I'd like to acknowledge. And this was through a partnership with Wits Health Consortium, and this was led by Mr. Segi Pillay, who will give you a short introduction on this great initiative that he has led. These sessions provide us with a bank of knowledge and is available to you, the participants, to use freely, but is not for commercial gain. I'd like to think of the NIOH as a lighthouse during the COVID storm, providing training material that is updated frequently as possible and relevant to give you guidance through this pandemic. But having this bank of knowledge is really nothing if we don't share the wealth of information that we have and that can help us navigate faster through the storm. Thus, the onus is really on you, the participant and the employer, to disseminate widely, to raise awareness within your workplaces, and adapt the tools to your specific scenarios. implement, monitor, and evaluate your controls and your interventions, etc., and determine if the impact, if there really is an impact on reducing the infections and behavior change within your workspaces. And if not, then review your systems. We all have a duty and a responsibility to reduce exposure within our workplaces, so we all play a very critical role in affecting change. And let us utilize this power to the best of our abilities. With that, I'd like to thank you again for joining the session today, and thank the entire NIOH team and the Wits Health Consortium team involved in organizing the session. And to our panelists and our guest speakers, thank you. I wish you a productive session, and be well and do stay safe. I hand over to Ashraf, the Program Director, who will take you through the proceedings. Thank you. Over to you, Ashraf.
Thank you very much for that. That was Dr. Tanusha Singh. She's the head of the COVID-19 outbreak response team at the NIOH, as well as the head of the immunology and microbiology section that has made a significant contribution to these webinars as well, together with the other sections. I'm going to immediately hand over to Mr. Segi Pillay, who is the Chief Operating Officer, I hope I got that right, Segi, of the Wits Health Consortium, with whom we are in partnership on this particular one. Over to you, Segi.
Ashraf, thank you very much. Ashraf, Tanusha, good morning. Jamison, lovely to see you after a long while. Just a few comments from me, and apologies for my hair. I tried to give myself a haircut yesterday, and that's the end result. I think Tanusha gave a really excellent overview of the value of this program and why the program was put together. Just to highlight a couple of points. I mean, firstly, I want to acknowledge the partnership with the National Institute for Occupational Health. And I think many of the participants already know, you know, this is NIOH and NHLS are both very important institutions that are part of the South African public health system. And they've been playing very critical roles during this time of uncertainty and this time of sort of concern amongst citizens in the country. And they played very, very critical roles. And we are very pleased and privileged to have partnered with NIOH to deliver this program. These programs, you know, NIOH will continue, but the program that is being funded by the Health and Welfare HWSETA will be coming to an end shortly. But the good news is that several of the other HWSETAs are also looking at expanding their footprint, and Jeanette and myself have been actively engaged with many of the HWSETAs. Jeanette has put in a massive effort to try and get these programs accredited, and at very short notice now, there's really good progress made on accrediting these programs as well, because we have to also start thinking post-COVID. I mean, clearly there's going to be something else that will come in the future, and all of the lessons from the experiences and learnings over the last couple of months and the next year or 2 years are going to be quite important in terms of us managing any other outbreaks in future, or any other pandemics in future. And believe me, we are going to get that coming up. So we're really grateful that the Health and Welfare HWSETA made the funding available. We're doing really well. There've been, you know, already over 15,000 people that have been trained. I know NIOH with their other training programs have reached out to even more people. The programs that Tanusha had indicated is information, it's knowledge, it's skills for you to take an active role in mitigating the risk associated with COVID-19. And it's not just the roles in the workplaces, because these skills can be used out in the community, in your own homes, you know, when you're out shopping, etc. So use this in the way that we can start making significant impact on the spread. So we want to thank the Health and Welfare HWSETA. We hope that we've been able to cover the most critical topics. And if there are topics that haven't been covered, there's still some time. You can raise that with us, and we can see how we can incorporate those topics into the remaining programs. But hopefully we'll be able to continue these programs with other funding from the Health and Welfare SETA. Part of this was also to provide data. So those individuals where data is an obstacle, we are providing data, and that's provided through the Health and Welfare SETA. It's important that we use the data for the purposes for which it was intended. My final comment is I hope that you will use this information in the way that it's intended. You take collective responsibility, irrespective of whether you're part of labor, whether you're part of management, whether you're occupational health and safety officer. We all have our individual roles to play those roles, and I think that we will see the situation beginning to change across in Gauteng, Eastern Cape, and KZN, where the problems seems to be greatest at the moment. But we will get over these issues. Thank you very much for supporting the programs, and I hope that you would enjoy the rest of this section. Ashraf, thank you very much.
Thank you. That was Mr. Segi Pillay, the Chief Operating Officer of the Wits Health Consortium, and we are in partnership with them for this specific duration, whilst the Health and Welfare SETA is providing financial resources for the series. And as he indicated, unfortunately, this is going to be concluded soon in terms of the objectives that we set for this. So briefly, I need to take you through a bit of administration, and I'm going to quickly share with you a few slides in order to bring the key aspects to your attention. So, the first slide starts with, it's this one. There we go. So I'm not sure if colleagues can see that. I may need to maximize that. One moment. Is that visible? Okay, so we've gone through the welcome. This program is dealing with the management of persons under investigation, PUIs of COVID-19 experiences in different sectors. And as Dr. Tanusha Singh, the chairperson of our COVID outbreak response team, has indicated, we're dealing with different sectors. The program you have received, but a few just quick administrative and logistical details. For all those who are participating in this particular session, can I just check, can people see this particular slide? Can I just have somebody respond with audio quickly from one of the panelists? It talks about the contact details for the admin team.
Yes, I can.
Great, thank you very much. Just a quality check. And so for any attendance certificates that you require for today's session and other sessions we've done in partnership with the Wits Health Consortium, as well as any data related queries that you have, please contact the admin team at hwstraining@witshealth.co.za. This I will again just do a quick round of slides at the end of the session, just around 12:30 when we finish. With regard to CPD certification, the NIH is certified with a number of bodies for CPD certificates and CPD points. So that's the slide that deals with that. Well, key thing is to just note that a link will be emailed to colleagues, to the attendees, and those who are members of the qualifying professional bodies and who are in good standing, obviously, with those bodies, will have to do the online questionnaire. For those who don't require the CPD points, the attendance certificate would be covering your particular need. So access, this is a very common question, access to COVID-19 presentations, etc. Just to remind everybody, the COVID-19 workplace videos, audio recordings, presentations, posters, and all the other COVID-19 resources, as Tanusha's indicated, is on the NIH website. That is www.nih.ac.za, and this particular website is zero rated by a number of the mobile service providers as well as an internet service provider. The email address there is for all other related queries. We have a Twitter handle that you see on the screen there as well, and for the urgent and emergency sort of queries, we have this hotline for the sector that we are supporting. Okay. So for the webinar housekeeping rules, we can accommodate up to a maximum of 3,000 logins. Once that is full, unfortunately, people will not be able to join. What is important, because of the number of attendees we deal with, we cannot have the microphone and video feed on for everybody, so that is muted. You'll have to use the question and answer function. That is the two bubbles at the bottom with a Q&A, the question answer bubble at the bottom of your Zoom window, and that's where you've got to type only your questions, please, only your questions. No admin with regard to certificates, CPD, or anything else, or if your sound is bad. For that, we have the chat function, and that's the other single bubble with a chat one. If you don't want the chat as people are typing to pop up in front of your presentation window, you can double click the chat icon. It will pop out as a floating window, a box which you can shift to the right or the left, as long as your slide screen is not filling the whole monitor, your full screen. Okay, so that's just a repeat. I'm going to stop that, sharing that now, and I'm going to introduce you to the program. And one moment, I did have the program there as well. If I could just escape there, 1 second. There we go. I've got the program as well. So just to then share with you the program. So as you can see, if I can just do that. As you can see, it's not filling the full screen, right? There we go. We have had the welcome by Dr. Tanusha Singh, the head of our COVID-19 outbreak response team. Mr. Segi Pillay, on behalf of the Wits Health Consortium, has done a bit introduction. And now we're going to go to our key presenters, and that's the series of topics, experiences in the mining industry, keeping in mind that our topic is dealing with the management of persons under investigation for COVID-19. We have experiences in the health sector, and we have experiences in the aviation sector, as well as the municipality local government sector. And the series of presenters is Dr. Jameson Malimela, and I'm now going to ask Dr. Malimela to just get ready to share his slides. I'm going to stop sharing this program. So good morning, Dr. Malimela. Thank you very much for making the time and availing yourself to share your knowledge and experience in your sector with all of our attendees. Welcome to this particular webinar. Over to you.
Good morning, Ashraf. Good morning, everyone. I'm uploading my slides now for sharing. Just a moment. I hope that is visible on your side.
Yes, you'll just have to maximize it for us, Doctor. At the moment, we can see, there we go. Thank you.
Thank you so much. Yeah, it's a pleasure for me to give you the experience of what is happening in the mining industry. And as you say, the book of COVID-19 is still in writing, so we don't really have anything as a reference except for our individual and collective experiences that we commonly share in this pool. So whatever you can take out of this discussion is what we have learned so far. As we say, it's not complete, and we take it as such. I work for Sibanye Stillwater as a Senior Vice President, Health and Wellness, and most of the experience I'm going to share with you here will come from the collective effort that came from all our healthcare workers in Sibanye Stillwater. In addition, we also have several other people that have contributed to this conversation. Because we're a publicly listed company, we just have to make this statement that we're not trying to sell you our shares. So please, we not say go and buy our shares, either in New York Stock Exchange or in Johannesburg Stock Exchange. I would also like to just say the presentation will have acknowledgement for people that have contributed. And I'll give you the context of SARS-CoV-2 in terms of preparedness, and then also go through the case reports and experience, and then we'll conclude, deal with the questions and answers, and then if there are any closing remarks, I'll handle that as well. Really, this presentation wouldn't be possible if I wasn't employed by this executive team of Sibanye-Stillwater and the healthcare workers who are our frontline staff, the human resources that allowed us to really look after the 88,000 workforce, and the integrated services that, you know, as you will see as we go along, that this is a transdisciplinary approach that we're being enabled by several departments within our own organization, and every other employee who contributed their data here. And of course, organizers of this webinar, the Minerals Council of Southern Africa, wherein we share a lot of industry policies, and then any other person that I'll reference as we go along. It is very important.
Apologies for interrupting you, my sincere apologies. There are some comments in the chat box that you are a little bit too soft, and there's a request for either the volume to be increased or for you to perhaps move closer to your microphone. Sorry for interrupting you.
Let me just adjust this. Can you hear me better? Anyway.
That sounds a little bit better, thank you. I guess it's proximity to the microphone.
Yeah, I think so. Yeah, so given the nature of COVID-19, and because we're talking about experience, I felt that we should just reference this to the WHO interim guideline that was issued on the 7th of March 2020. And, you know, when there were no cases, when we had sporadic cases, and when we had cluster of cases, and currently where we have a community transmission. And you can see the objective of you know, phases 1, 2, and 3 were all about stopping transmission and prevention of spread. And I want everybody to get this. Where we are in community transmission, the objective is to slow the transmission, reduce the case numbers, and end community outbreaks, because these objectives are very, very key for all the stakeholders to understand where they will be playing their roles in mitigation of reduction of COVID-19 in our society. And I would also like to reference, you know, this in a systematic way. And I felt, you know, the WHO health systems framework actually makes perfect sense, so that you can unpack very complex things that happen in health systems. So at number 1, there you will see our experience from leadership and governance. We had the COVID-19 Executive Steering Committee headed by our group Chief Executive Officer, which meant that at the highest of the organization, we had support. And this happened quite early. As early as February, we already had this set up. And in that steercom, we also had a working committee just to deal with what's going to happen. Well, we don't have any branch in China, but at the time, we were actually contemplating what could be the impact on global logistics, everything, because we are in mining. So we started working there on business sustainability, impact on the workforce, and so on. And the second thing was thinking about health services, because in the mines, we're lucky to have primary healthcare services, occupational health services, and then hospital or secondary healthcare services. And at that time, also around February, the concern was also about mine workers who were in SADC countries who were on leave. Remember, at that time, there was no case, as we spoke about February, this was still in China. And we didn't even see anything that was giving direction as to how to handle it. So the most information we could deal with was WHO, but we had employees that were inside the countries we needed to return. I remember it was over 1,500 of those employees. So that was the responsiveness in terms of the health system, where executives actually made sure that we can begin addressing that. And I can tell you, we already managed to get a protocol as to how to return these employees to avoid COVID reaching us at that time. Then the information technology was very important, because all these 6 pillars of the health systems in terms of the WHO framework have to work together in order to deal with this. So we had a Click Medics app at that time, which was going to be deployed to screen employees who were coming from Mozambique, Lesotho, and Swaziland before they could come. And at that time, because there was no clarity on regulation or legislation, we're saying if someone has got symptoms as defined by WHO, they should not be allowed to come into South Africa. They must be handled by TEBA, which is the organization that we've been working with. That was the early response in terms of the experience that we were looking at. And we also had occupational health systems which were getting ready also to deal with this, because in mining, most of you will realize that you require a certificate of fitness. This will come in the last slide of this presentation, because the Mine Health and Safety Act is very prescriptive that you can only work on a mine if you have issued with the certificate of fitness. And of course, the technology, as the pandemic evolved, yes, we managed to get a PCR access through private laboratories, because 88,000 of our workers in Sibanye-Stillwater are covered for their health. And at that time, the access to this technology was already made available. I can tell you, we even went further to provide for capacity for PCR testing in the country. It's a separate discussion, that one. And the health workforce. So we looked at 2 areas: the impact of COVID-19 on services, the existing services, as well as provision of COVID-specific services. I'll unpack this as we go along. And then lastly, in addition to our usual financial plans for 2020, we then had, I must say, enablement from that group steering committee that anything that we needed to mitigate COVID, money was made available. So that the budget for COVID was not restricted based on what we had planned for 2020, because this was entirely unplanned. And all of this, in terms of our health systems accountability, we wanted to make sure that we can account for persons under investigation, in short. Now, these critical preparedness, readiness, and response actions to COVID-19, when you put it together based on what we have as a framework from WHO, what we have as a framework of Sibanye-Stillwater, which, by the way, aligns with most of the mining industry through the Minerals Council of South Africa. Then, when there were no cases, as we say, we had a SADC excellent employees to deal with. And then the business response through the steering committee had an output of Sibanye-Stillwater protocols, which were signed off. Remember, I'm saying before we even had a case in South Africa, right? And that was around February. In March, when sporadic cases were coming through, we had our first case in Rustenburg on the 16th of March. It was a 25-year-old contractor that went to Mpumalanga and came back and had symptoms and was tested, by the way, by a private GP, and we got the results as confirmed. And the whole cascade started of isolation. He was actually admitted by the General District and kept there for about 8 days, and then he was discharged to his own home because he was mildly symptomatic. And remember, around that time also the issue of what next to do was really a mirror of what WHO was prescribing. And we also reviewed our protocols due to the regulations that were coming forth. And then, as we're seeing the clusters in May, in Tembelani Shaft, which is in Bujanala district, we had over 100 cases on the mine. And yeah, we learned a lot. There was a lot of media attention there because, as you know, with pandemics of this nature, there's also a lot of fear. We managed to get that under control, and then we managed to really make sure that everyone could be assisted through that. Then we had an issue of isolation. We had an issue of quarantine facilities, and then we also had hospital admission challenges. But we learned quite rapidly that no, we didn't drop any ball during this, because it was really quite early, and there was a sudden surge in the number of employees that got confirmed for COVID. Then came June, July, and we saw the surge in cases, which was a mirror of what was happening in these districts. We saw, as I mentioned, Gujana Line, Rustenburg, then Marikana, then West Base, which is your Carltonville area, then our Free State operations in Welcome as we speak now. So we actually saw the demographic surges based on the district dynamics. And I must say, you'll see in the graphs that actually we are actually in a better space than we were probably 3 weeks ago. Yeah, so the other pressure was increase in occupational health services and PHC capacities, because business as usual had to happen. Then we had to accommodate COVID-related services, which included mental health services, people that required purely quarantine, people that required purely isolation. I must say we had a mixture of on-site facilities, we're lucky to have that, as well as using private facilities for this. And I must also emphasize that right now in July, we're dealing with the concept of the vulnerable employees. As you know, this is not a simple matter. It impacts on livelihoods of employees as well as life. And there's also about 35% of the workforce that has not returned, but there's also a workforce that is already producing. So, and they're having all what is defined in the Department of Health guidelines as vulnerable employees. So we're working very hard on this so that the definitions can be aligned with the practicalities. I mean, we're talking 88,000 workforce. Right? So the next slide is really just to show you how our health system is accounting for persons under investigation in numerical terms. But then now, this is one of the protocols that we have as to how we get to manage in the workplace. I do have another slide that I'll show with you which follows this one. So the main thing is that if somebody develops symptoms in any of our health services, as I mentioned, primary health care, occupational health services, through emergencies or private GPs, will then put them through a process of accountability to say all those public health measures of identification of the case, isolation, contact tracing, and follow-up, which we apply all that. So this is what happens if someone is at the workplace when emergency response is being asked to assist, because we provide 24/7 health services in our operations across the board. The next slide is how contact tracing is being done. It's based on teams that are deployed across the mine, and they do interviews for infection and prevention nurses that are dedicated to guide everyone else. In addition, working together with the district health in doing contact tracing. So the whole accountability is based on what we have in the health system, as I referenced earlier on. Now, as we said, the trigger points for this will be primary health care. And here a detail is that we do have people that have medical schemes, so you can understand the challenge. So often we'll have the test result that is positive. That is the only thing that we know. And because we've done in our protocols, employee education, everything around social distancing and so on. And we're saying if you have symptoms, don't come to work. So the private GPs help us with the identification of positive cases. Then we do the usual stuff of contact tracing in the workplace. And I must say, in this space, we also have employees who were never recalled, who are still in their homes because of the lockdown. But we still get the positive or confirmation of PCR, SARS PCR coming our way. And certainly, at times, we see even deaths. That's notification of death as a result of COVID is the only trigger for some of the employees that have not as yet returned. We, however, still have a small proportion of the employees who are responsible for their healthcare through our in-house services who have not taken medical scheme. We also provide credit to return to work kind of services. And for routine occupational health services, we're still doing certifications, pre-employment, employment, periodic exits, and all that, obviously, with the protocols that take regard for COVID. And when every employee that has had a COVID confirmation, we post-COVID de-isolation examination so that we can better assess whether these employees can continue working, because the de-isolation, as you know, does not necessarily mean that somebody has recovered. So those services continue with very strict protocols. And of course, there are hospital admissions as we speak, and we've seen quite a number of employees that actually go for scans, MRI scans, CT scans, and they get a COVID test done on them. And voila, it comes positive, meaning that they were asymptomatic. Whether they were at work or somewhere, we still follow the same issue of assessing the risk of contact, and then we do the same whether there is a need for quarantine or no quarantine. And we're saying private health professionals are assisted. We also have families that do get SARS CoV-2 detected, and then those families will alert us through whoever is our employee, and we do the same in the workplace. So really, don't take too much of the graph that you're going to start seeing now on your side. It's just to show you that we are accounting, our health system is accounting for all the cases that we can see. This is the group-wise, and you can see that we really reached quite over 1,500 cases, all in all, since the 16th of March. But you can see that our 7-day rollover figures are very encouraging. But as we say, these are epidemiological issues. You cannot say, we're winning, because this depends on the public health issues that are happening around us. But this is how we account to give, idea of what impact the disease is having in the operations. And then this is a split in the complexity. That's why it's even very important that you can't compare one company to the other. The complexity is that these operations are in district health, which have got their own dynamic. So you can't take this, what I'm showing you, and say, I'm going to compare this with the Harmony, with Anglo or something, because these companies have got different dynamics. They may even share a district. That's the only time you can compare maybe a division of a particular company that it's a public health issue. But what we do see is that there is a synchronization of increasing in case loads in the communities. We also see a reflection in the workplace. As I said, the dynamics are quite huge. On a daily basis, we account for what is going on in our business, and then we can show, as this one, the last update was on the 2nd, but on a daily basis, we do account for positive cases across. We also look at the number of deaths happening. As I said, majority of these deaths, I must just share with you, over 99% they had comorbidities. It's not the purpose of this discussion for today about which comorbidities, but yes, they have comorbidities. And then we also look at those that have recovered. As I said, in our organization, de-isolation is not equivalent to recovery. We still have to make sure that our strict occupational health services determine whether our employees have indeed recovered or not. As you can see, the total number of de-isolation is quite higher than the recovered. So in conclusion, it's very important that we understand that when employees become PUIs, this can happen, from home, from work, or in community health facilities, hospitals. So our health system is designed on a mind that takes accountability from these diverse areas. and private GPs get involved. Sometimes we see a death certificate, sometimes we see district health officials knocking at our door. So we follow the same, because as we say, this is a transdisciplinary condition. We cannot win alone. We're looking for everybody else who can assist us to make sure that we can reduce transmission of COVID-19. And I must emphasize that the mental health for health workers is very, very paramount. What we have done in our organization is to involve an independent party where our healthcare workers can phone in, get support, and get additional referral. And we also have in-house medical teams that are also supporting at a clinical level, the psychologists, whatever kind of mental health services that are required. Yeah. So the issue of public health measures is still key in our intervention, because this is a public health condition to follow through, and making sure that we interact with all the stakeholders that are in that space, so that we can make sure that we don't have any negative impact on transmission. As I say, even our healthcare workers are given all that is required in terms of proper PPEs, and that the education and training has happened amongst them, and that they also carry through to their families. And also that in all our healthcare facilities, we ensure that there's physical distancing that is taking place, that is a compulsory PPE, including the type of masks to be used. And also the question of vulnerable employees is being emphasized, including most of our healthcare workers that would have this, also using our own risk management to make sure that those that should be removed from face-to-face can be done, and those that can work virtually can be given the opportunity. And this is really the last slide on my side. Thank you.
Thank you very much. That was Dr. Jameson Malemela from Sibanye Stillwater, sharing the experiences from the mining industry in one particular employer. So you would need to just close the sharing. It is the red icon right at the top. Thank you very much. So our next presenter is Sister Lesego Siabelo. And Sister Siabelo, while she's opening her PowerPoint presentation and sharing it with us, I'm just going to do a quick brief introduction. Sister Lesego Siabelo is an occupational health practitioner at Dr. George Mukari Academic Hospital in Ga-Rankuwa, Gauteng Province. Sister Siabelo holds a diploma in nursing science, a BA CUR, a BTech in occupational nursing, and currently an MPH Masters in Public Health student at the University of Pretoria. She has over 10 years experience practicing as an occupational health practitioner in a health facility, and that's a provincial tertiary hospital and academic hospital. So Sister Siabelo, thank you very much. You may proceed. Just unmute your microphone.
Ashraf.
Yeah, thank you. Good morning.
Good morning, everyone. Yes, I will be presenting from Dr. George Mukari Academic Hospital. These are my experiences as the occupational health nurse. My slide is not moving.
Okay. Do you have the arrows that you're using?
Yes, I'm using the arrows.
And if you click on the actual slide?
Okay, all right. This is the layout of my presentation. It will be about the background of the institution. I'll look at the overview, the stats summary, identifying COVID-19 suspects in our institution, managing suspects, dealing with challenges, enablers, our reflection, way forward, and acknowledgement. This presentation is more about occupational health and safety. We're looking at our employees. So Dr. George Mukhari Academic Hospital, formerly known as Garankuwa Hospital, was built or established in 1974. It's an academic institution, one of the 4 in Gauteng province. We provide all 3 levels of services. Being an academic institution, we have 24 clinical departments and 1,652 approved beds, of which 1,592 are active. We have 166 beds available for COVID. We are looking at PIU. We render high care services and ICU services. And these beds are distributed in 8 units dedicated for COVID-19 management. Then the drainage population for our institution is 1.7 million. We also have referrals from other provinces like Limpopo and the Northwest Province. Our total staff establishment is at 4,407 at the moment. Then this slide shows the trends per category of our employees on daily basis. When we had the first case, it was on the 13th April, and the blue color indicates the nurses, the orange doctors, and more on the yellow will be our allied, and the gray the support staff. And we've seen high number of infections on daily basis among nurses between the periods of April and May. Then the number increased and we saw more doctors also getting infected, and majority of our allied professionals also. In summary of our statistics, as of the 31st July, we've had 307 employees who tested positive. 221 of them are covered, 86 are still active. And cumulatively, we've had 8 employees who were hospitalized, and we lost 2 of them. May their souls rest in peace. In breaking down these 307, 197 are nurses, 37 doctors, and 73 support and allied staff. And this distribution is throughout the hospital, not a particular department. In identifying COVID suspect, we've implemented a protocol on daily symptoms monitoring, and this is being managed by unit managers. So the monitoring will be done in the morning when staff report on duty, and before they exit or before they knock off in the evening, the monitoring also will be done. Should there be any symptoms monitored or detected, then the employee will be sent for testing and quarantining will be initiated. So we have conducted an active COVID-19 surveillance campaign as Occupational Health and Safety, where we are doing the COVID-19 medical surveillance and testing. This process took place between where we've reached 641 employees of all categories. And from when we started, we identified 6 nurses who were positive. And as we progressed with the testing at the end, we had 29 nurses who tested positive, 2 doctors and 1 cleaner. This was only through the active surveillance. And breaking down the active surveillance timeline, as we started from the 6th to the 12th May, we targeted accident and emergency department, ICU, theater, and also we included the OHS and CTD personnel, as this department, OHS and CTD, were the one who were doing surveillance. So we are calling them the surveillance team. And we tested 231 between that date of the 6th and the 12th May. Everyone, as we did the surveillance, the medical screening, they were all asymptomatic, and the results came negative for that 231. And we continued from the 25th to the 29th May in medical ward, because our program was scheduled to say for this period we'll be in this area, just like that. And we tested 86 employees in the medical ward. 85 of them were negative, while 1 was positive. And also, they were all asymptomatic. Even the person who tested positive was asymptomatic. We received the results of the positive employee. It was on the 5th when we received the results. And during that period of the 1st to the 5th June, we were still in the medical wards doing the surveillance, so we tested 47. This 47, they tested negative, all of them. Because of that positive case of between the 25th and 29th, whom we received the results on the 5th, we did now intense testing in the medical corridor between the date of the 8th to the 12th, where we tested 284 employees within the medical department, and 38 of them were positive. And then we moved on to the date of June to date, where we've seen an increased number of positive cases, where 307 positive, 8 were hospitalized, the 86 that is active, and the 2 deaths that we've experienced. And managing our suspects, like I mentioned, after we have identified that they have some symptoms, they will be quarantined. We're using the old protocol, where on the 8th day, they will come for testing. And when they are negative, they will continue with their duties or resume duties. If they are positive, then the isolation procedure will be put in place. We had some challenges. Yes, occupational health and safety. Lack of teamwork is the main thing, because when you talk employees, everyone thinks that the employees, the responsibility of occupational health and safety. Even to implement the daily symptoms monitoring tool was a challenge, where some departments will feel that they are being given extra duty. So it was a challenge. And we also had challenge of poor response to compliance with standard precaution. And after we had the first case being positive, is then that the attitude changed. Maybe now people started seeing that COVID-19 is within us. That daily monitoring was being done now, and the compliance improved. Then lack of psychological support or preparedness, as we have lack of EAP services in the institution, was a real challenge, because now it had to be the responsibility of OHS to support employees who tested positive, and the colleagues also, because now once we've heard that your colleague is positive, you know, that fear and anxiety that arose, so we had to deal with that. And some of our surveillance team from OHS and CTD, have mentioned that they were surveillance team, they got infected. So it was a big topic. We have some enablers, the OHS team that is so committed, that comprises of 3 occupational health nurses, 4 general professional nurses. We have 1 occupational medical specialist, 2 medical officers, 2 registrars, 4 occupational health practitioners, enrolled nurse, auxiliary nurse, and the admin officer, who, when we did this project of medical surveillance and testing, we reached out to the employees. We went to their departments, because from the experience, when we centralized the service, the attendance in their departments, then we assessed the daily symptoms monitoring tool for compliance, and also we were checking on the use of PPE. We'll be auditing that compliance with use of PPE. We did inspections as OHS, we conducted training on this COVID, and also we did telephone follow-up on the heavily burdened positive employees. And also we are rendering the return to work consultation, hence we are having that huge number of doctors. We had the assistance of nursing, the clinical teaching department personnel, that increased our manpower. That's why we managed to reach that huge number. The trade unions' active participation, as they were part of the war room that was established health, where the beginning, I think it was around end of March, where they assisted us with baseline assessment and gave us recommendations as to what needs to be improved. The support from Sinekekele K-Waste trauma debriefing, where I contacted them to assist OHS with managing trauma cases related to this COVID, and also the support from Sefako University Community Health Department also assisted a lot. That's where we get these two registrars from. Our successes and achievement from the support that was given by NAYO, we managed to develop our hazard identification and risk assessment, the biological hazard risk assessment. Some recommendations were fully implemented, like no mask, no entry policy that was implemented, the social distancing, the sanitizing. And we've realized from the surveillance results that most of the results were centralized in certain departments, like they were clustered, and we did the assessment in those areas to find out really what is really happening, because at that time there was no patients who were positive. It was already found was that tea rooms could be the cause, because in the tea rooms people will remove masks, and being colleagues, we trust each other that much. Then we introduced the policy to say we'll be having staggered tea breaks and lunch, and few people will be accommodated in our dining rooms. Way forward, further enhancement of standard precaution, especially this hierarchy of controls we have to look at. Our hospital is very old. We have infrastructural challenges. The ventilations is the challenge. So these are the things that needs to be attended to. With the data that we have to do further analysis on comorbidities for those who tend positive being symptomatic and asymptomatic. So we have to go work on this data to determine numbers exactly. And also to have a survey on mental wellness or work relations between our staff members. Then my acknowledgement goes to all employees of our institutions who cooperated when we initiated the process, the Occupational Health and Safety and Clinical Teaching and Training Department, trade unions, the Community Health Department at SMU, National Institute for Occupational Health, and our management. I thank you.
Thank you very much. That was Sister Lisejo Siabelo, who is a practicing and experienced occupational nursing practitioner at the Dr. George Mukari Academic Hospital. Thank you for that. I'm going to encourage all our panelists, and there's a large team of panelists from the NIH, to continue dealing with the questions in the Q&A box. A reminder to our participants, please, no administrative questions in the Q&A box. And just to remind colleagues that I've provided the Health and Welfare, the Wits Health Consortium's email address for the certificate of attendance questions that you've had. Okay, so, and then the Q&A box at the bottom of your Zoom window is where you type only your questions. Please, if you could do that. Any other items would be for the chat box. So now I'm going to ask Dr. Kuzwayo to just prepare sharing his slideshow. I unfortunately did not have a chance, Dr. Kuzwayo, to summarize your CV, your curriculum vitae, but I'm going to just ask you to just briefly introduce yourself once you have your slides available. So do you have your slides open, Dr. Kuzwayo?
Not yet. I'm trying to.
If it's open on your laptop or computer, then you can click the green button at the bottom of the Zoom window. There's a green button with the little arrow showing up, and that will allow you then to share. And then
there's a notification that says a host disabled participant screen sharing at the moment.
Okay, I'm going to ask my colleague in the IT department to assist us with that. Apologies for that. So if the IT colleagues could just ensure that Dr. Guzwayo can share his slides while that is happening. Also, for those interested in the CPD points, a reminder that after this webinar, we will be sending you a link, and only those who are members of a professional body that's recognized would be able to then use the link for the online test. There's an online test for the CPD points. I see that Dr. Kuzwayo, thank you very much. Your slides, and you have it in full screen. I'm handing over to you, Dr. Kuzwayo.
Thank you very much, and it's an honor and a privilege to be invited into this by NIOH. My name is Dr. Kuzayo. I'm sharing my experiences in the aviation industry. I have worked since 2016 as an occupational medicine practitioner at King Shaka Airport, as well as OR Tambo Airport as an occupational medicine practitioner there. I'm also a designated aviation medical examiner by the South African Civil Aviation Authority. I also sit as a medical assessor for the Department of Labor for Compensation for Occupational Injuries and Diseases Act. And I'm the current board chairperson for the AIDS Foundation of South Africa, and a medical and an occupational medicine practitioner for the South African Reserve Bank at the moment. I think that's who I am. This presentation has got two parts. One of them it's just the experiences as I indicated on my side, and the second part is also by the South African Civil Aviation Authority, and there's a lot of information in this regard that has been provided by Dr. Lesego Bogatsu, who is the current senior manager for the South African Civil Aviation Authority.
Dr. Guzwayo, do you want to move your slides? If you click on the slide, does it move?
Click on the slide. Yes. So the topic, of course, is management of persons under investigations, and we wanted to concentrate mainly on the experiences in the aviation industry. What I wanted to provide is a bit of background, because this is an environment that has got a number of role players, and the most important of those role players is the WHO, in terms of the international health regulations, the ICAO, the International Civil Aviation Organization, and of course the South African government through the Department of Health, the Port Health component of the Department of Health, the National Department of Transport, with the regulatory authority, which is performed by the South African Civil Aviation Authority. The other important role players is the airports management companies, and the significant role player in this regard is of course the Airports Company of South Africa and others, as well as airline operators and the other Aerotropolis Commercial Corps and the travelers. The response to COVID-19 was, of course, going to involve a lot of collaboration from all the stakeholders that I've mentioned, but I wanted to single out the existing collaboration through the programs like the Collaborative Arrangement for the Prevention and Management of Public Health Events, which is a program that has existed since about 2003, and which was aimed really at containing communicable diseases and realizing that communicable diseases can affect the aviation industry and involve a lot of countries at the same time. And also to leverage on the existing port health services and of course the South African Civil Aviation Authority in terms of regulation and management for the airports Company of South Africa and other managers. This is the graph that was shown, a lot of us will be familiar with because it was projected by Prof. Abdul Karim. And I just included this to show that the aviation industry was unfortunately the first to be hit by the first wave of the South African epidemic, as it described it, because this is when the epidemiological criteria was still very important in the case definition, where we had to deal with people that come from China, which then changed to Spain and so on and so on. And so we found that the aviation industry was really hit way before there was local community transmission. This then led to a number of things, which one of which was access control, both in terms of the international flights that were no longer allowed into the country, depending on that epidemiological criteria, but bringing it closer to home. It meant that we also had, at the airports, had to have limited number of entry and exit points so as to screen employees, visitors and constructors. We had to design a digital platform which was implemented to screen particular employees prior to them entering the workplace. And the screening was constantly being adapted to the changing case definition. And all positive screens were then referred to the occupational medicine practitioners, which were working closely with Port Health Clinic on the other side. In terms of management of suspected cases, I just want to mention the salient points, because we have also been following the guidance from the National Institute of Occupational Diseases, the WHO, and the Department of Health. But I think what then happened is that all the suspected cases were given masks and sent to a secondary isolation site. There was communication with the occupational health clinic for referral purposes, and in a number of these airports, then you would have a clinic on the terminal side and a clinic on the air side, or where people are arriving, and mostly the one on the air side is the one that is run by Port Health authorities. Contact tracing then started immediately. That it became important to have record keeping, and where the PUIs and where suspects were found, workplace access was deactivated, so that employees were not allowed to come back to work. And managers were then supposed to provide regular contact and support, particularly to the employees who found themselves on quarantine and who very early on did not come to work. Part of the important aspects in the aviation industry is the aviation personnel themselves, and this medical report and examination is obviously based on licensing by the Civil Aviation Authority, which requires that the certain procedures need to be followed in this regard. And the designated aviation medical examiners had to provide certificates for a lot of these employees and personnel for them to continue their duties. And so where we found issues, and then you'd find that there would be medical reports that were required, and that no other household members would make a determination if there are no other household members that have got an illness, at least that there's been 3 days that has gone through past the recovery before people come back, and that there were no respiratory symptoms. These were some of the initial ways in which we looked at this. And of course, the challenges that we saw, particularly in the aviation industry environment, is the social distancing because of the amount of people that are there. It also became difficult to arrange transport for employees who've tested positive, who needed to go, and initially we had just designated hospitals where employees who tested positive needed to go, or employees who exhibited symptoms needed to go. The other challenge was really creating an environment of honesty where employees feel safe to disclose their conditions. This part of the presentation really talks to what ICAO does, which is the International Civil Aviation Organization, in terms of making sure there's a clean crew, clean aircraft, clean airport facilities, clean passenger, as well as clean cargo. And these are some of the areas where they look at aeronautical consideration, and as well as the facilitation considerations, which are based on declarations, passenger location, and etc. The factors that affect probability of disease transmission at the airport, possible routes of infection was before boarding the aircraft, en route to the airport by the public, in line at the check-in counters, and waiting in the gate area, access to aircraft, as well as other crowded spaces. Of course, then what we had to do was that the hand sanitization policy had to be instituted, where hand sanitizers were instituted to control the infection and to ensure that facilities are available for hand washing, increased frequency of cleaning of surfaces, the hazardous bins for disposal of tissues and PPE were put on, and then the management of air conditioning was also enhanced. The social distancing stickers, as well as signage, was put in to ensure that the social distancing of at least 1.5 meters between persons at the terminal building. The PPE at airports personnel was provided, and that, you know, it had to be appropriate, and that the level of PPE really depended on the health guidelines and the health risk assessment for those particular people. But education on PPE usage was also very important, because no PPE provides 100% protection. The facilities, and we had to ensure that protective screens are installed in all the facilities, particularly the check-in counters, and then we had to analyze gate utilization and ensure most efficient use of gating, enabling sections to be closed to reduce maintenance and resources, and also to restrict access to optional or high-risk items such as massage chairs, water fountains, children play areas, and all these common areas, and that only travelers were allowed in the airport buildings. Of course, the screening process, as colleagues would understand, there's a lot in terms of its sensitivity, and I've seen the colleagues that presented before me that there's a lot of cases that were found by actively looking for them, because when you actually do screening, you are actually looking at people that are presumed to be healthy people. But we had to put a formal plan to apply entry or exit screening controls at point of entry, you know, at the airport, and enable risk assessment of individual traveler in line with the international health regulations for 2005. The WHO also requires that the entry and exit requirements in terms of screening is done, and it should be based on scientific principles, and that shall not be restrictive in terms of international travel. This was the initial communication from the WHO. There is currently no standardized procedures for health screening at all the airports, and so regional airports make their own decisions based on the advice by the National Institute of Communicable Diseases, and also following on the regulations by the WHO, ICAO, as well as looking at international health relations. And there's no formal penalty for failure to implement exit or entrance screening at the moment. The screening for COVID-19, Airport Authority, in consultation with Health Authority where necessary, must ensure that entry, which is I've mentioned, and also we also wanted to ensure that there is the quarantine and isolation procedures that were in place, which of course affected airlines and affected operations negatively, particularly financially. The screening for For the virus at the airport, the primary screening was including the visual screening, the brief history taking, the temperature, as well as the perusal of the health declaration forms. The added measures that were put in place, particularly by Port Health, initially, particularly when the international travelers was not yet banned, is that Port Health authorities themselves were conducting thermal screening on board, and the passengers were to remain seated until they are advised by Port Health officials to disembark. I will skip this one. This just speaks to the interconnectedness of all the role players in the aviation sector and all the people that are involved in maintaining that the whole metropolis is aligned in terms of screening and in terms of dealing with the problem of COVID-19. The communication became one of the most important tools in dealing with the pandemic preparedness and planning, and the dedicated personnel that were allocated with responsibility for operational implementation of the airport preparedness plan. And this looked at the communication links internally, externally, and also dealing with the travelers. The airport personnel themselves, we continue to do symptom monitoring, and we deal with the training of the personnel. And what we do, these are the areas that we look at, which is hand hygiene, PPE, the disposal of PPE, respiratory etiquette, social distancing, the cleaning and disinfection, identification and management of cases, and roles, and different roles for different personnel. This, as mentioned earlier, that the aviation industry was one of the hardest hit industry by the COVID-19 pandemic, and a business continuity plan needed to be developed by a number of stakeholders for business to continue. And we know that a lot of companies went into business rescue during this period and still continue to suffer the effects of COVID-19. The infection control measures pertain to cabin environment management, and as well as social distancing and infection control, which covers all the aspects of infection control as indicated earlier. The passengers with disabilities, there had to be special requirements for passengers in that regard, because once they were on board, wheelchairs are provided, airlines were supposed to consider additional cleaning procedures to ensure they remain clean between each use. And if assistance is required to escort a sick passenger, PPE must be provided to passenger aides. I think I've covered most of the areas like I indicated. This has been a journey, and there's a lot of changes that have been made even in the aviation sector based on the new information that has been coming in. So there were responses that were based initially in the pre-lockdown era, and also there's a lot of considerations and new information that has come up that is currently being implemented in the post-lockdown era. And as you know, at the moment, the international travelers or the international airlines have still not yet been opened, and it's not yet fully functional, but there's a lot of planning in that regard, so that we are prepared in the event that it is opened. I just want to thank Dr. Lesigo Bogatsu, who made this presentation possible, particularly from the South African civil aviation point of view, as well as Dr. Tanga, who assisted with this presentation. Thank you.
Thank you very much, and thanks to your colleagues. If you could just mute your microphone, Dr. Kuzwayo. Thanks. So thank you very much to Dr. Kuzwayo, who has shared with us the experiences in the aviation sector, as well as thank you to his colleagues who supported him in preparing for that particular presentation. And I'm sure you're getting, as attendees, a very broad perspective of the different types of sectors and industries that are doing quite a lot on the ground. And who those role players are in order to ensure that the workers, the employees at workplace level is protected, and that the COVID-19 or SARS-CoV-2 is kept at bay as much as possible. So I'm now going to invite our next guest speaker, guest presenter. That's Dr. Moyagobo Reginald Setslagwe. Dr. Setslagwe is an occupational medicine specialist with more than 10 years experience of occupational health from various industries, including mining, construction, steel, chemical, and municipality. And I will just complete this introduction whilst Dr. Setslagwe is preparing his presentation slides for sharing. So Dr. Setslagwe runs his own consulting company focusing on occupational health program design and evaluations, occupational health systems gap assessments, assessments of vulnerable employees, incapacity and disability assessments, and drafting of occupational health procedures and protocol. So like our other guests, we are very, very happy to have Dr. Setslagwe sharing with us today the experiences from the local government and municipal sectors. Dr. Setslagwe, are you there? Can you just check your microphone?
Yes, good morning. Yes, it's still morning.
Good morning. Yes, it still is. 8 more minutes of morning for you. So welcome. And I'm going to ask you just to share your presentation slides.
Okay, let me call that. I actually thought you have that already.
Oh, my colleagues do have it. But if you have it on your side and your connection is strong enough, your bandwidth and internet connection, I'll ask you to proceed.
Yeah, no, it's fine. I've got it. Thank you.
So welcome, and handing over to you.
Thank you. All right. Okay. Is this visible on everybody's side?
Yes, if you could just maximize it, thank you. That's
okay.
Perfect. Thank you.
Thank you very much. Colleagues, good afternoon. I think it's still good morning. I'm speaking to you today. I am currently assisting one of the cities in Gauteng. I'm not looking at the entire city. I look after an entity within a city, which has got about 6,000 employees, and with about 16 sites, working sites. These employees and the 6,000 employees are not all of them office based. So you can, and most of them as well, there is a challenge in terms of they've got different levels of literacy. So I think this is definitely going to be different to mining, to aviation, in a sense of here you're dealing with employees who come and have to go home every day. As I said, level of literacy is also a challenge in some of the cases or in some of the employees. We are a team of about 9, myself being the only doctor, and I've got 8 nurses. So each nurse looks after 2 sites. So which automatically what it means is that the nurse has to, is not available per site at all times. And I mean, each site has about, in the region of about 2 to 600 employees, different shifts. And we provide PHC, primary health care. We provide occupational health, and of course, with the COVID pandemic, we now also added to their scope the clinical assessment And I'll come back to what I mean when I talk about the clinical assessment. The clinical assessment, we've given that to them, and also the testing. So we have ensured that all our nurses are trained to test. We, in collaboration with the Department of Health and the entire city, we have access to test kits, and we send our tests to NHLS. And this was simply to make sure that there can be accessibility to care by our employees.
Apologies for interrupting, Dr. Seslagoy. Are you moving your slides? You may need to click on the actual slide because we still see your first slide.
Yes, it is. I'm still on the intro.
Okay, thank you.
Yeah.
Apologies for interruption.
No problem. And as such, we had to implement, before we even get to having to be able to identify people, or what we call the persons under investigation. We had to implement a process that assists with the screening. And as I've said earlier on, 8 nurses, 16 sites, 6,000 employees. It wasn't going to happen. It wasn't going to happen by the nurses. So we had to implement a process that can be acceptable. That is, that respects confidentiality in terms of screening, because we realize that not everybody would be able to do self screening and be able to call in and say, "I'm not coming in today." So once a person has been screened, so bit of a recap. So what I've just said, in terms of screening, symptom screening, we could not implement self-screening throughout. In certain aspects, which is a smaller portion, that's where we've got the self-screening, it's still paper-based. And the rest is really assisted. And assisted is really mainly by line management. So we have the supervisors who are able to assist those who can't read and write to conduct daily screening. And out of that, anyone who is then identified as possibly having symptoms, is the typical questionnaire that is being circulated. I think it's been used by everybody, designed by, I can't remember whether it's the DOH or the NICD, but it's a typical questionnaire, yes or no. If anybody is picked up to have symptoms, 1 year is more than enough for us. We then put in place a system which goes to verification, and from verification is to clinical assessment. And this is where really I'm going to focus on, because that's where we're talking about, the person under investigation. This is where it starts to say, we've now received employees who have been identified because they said they've got a cough. The nurses now come in and actually start doing the assessment. But before even you get there, if this employee is picked up at a workstation where the nurse is not there, we ensure 2 things. One is immediately our systems allow for that person to be isolated. So each and every workstation or workplace, we have tried to identify a way to isolate those who have possible symptoms before they can be transported, or before they can be, they can go through a clinical assessment, telephonic or physical. And out of that, then of course, then the nurses, then the person will go if qualifies, will go for quarantine and testing, and which will then be the management of positive. This is just a recap really of what we've discussed in the past in one of our previous trainings. So in a nutshell, once a person has been identified by the nurses during that clinical, what we call clinical assessment, as possible with, you know, or meeting the criteria for testing, there are two things we need to we look at. One is we also establish in terms of medical aid. Does the person have a medical aid or not, the employee? The reason being that those who have medical aid, we found that they tend to prefer to go to their own doctor, you know, and therefore the nurse would then establish that to say, okay, when I go to your own doctor, we would then provide the employee with a referral letter to go to their own doctor. However, the transport will be provided. So we ensure that once we've identified a person to say possible symptoms which qualify, then we provide transport to the person's doctor, and from there the person goes home for quarantine while waiting for results. And of course, on return to work, then the person will be reviewed with. So the employee has to provide the results, feedback from the doctor to say, well, I was tested, it was just a flu, not a COVID-19, or I've been tested positive, which will then manage it according to our processes in terms of management of positive employees. Those who don't have medical aid, and the reason again why we distinguish this, as I said in my intro, is that, you know, for the 6,000 employees, not everybody's got medical aid. These are really blue collar. Some can't even read and write. They don't have, not everybody's got medical aid. So we have made provisions. So the nurse will then identify this person needs to be tested. From there, we have testing sites, including the actual nurses, as I said, all of them are trained, they have test kits. We'll then determine if the level of treatment required. If it's just a minor cough, or if it's just a minor cough or a mild cough, you know, with a bit of a scratchy throat, nothing much that requires really, you know, a higher level of treatment, then the nurse would provide the necessary supporting treatment, would then take the person through for testing. Either the nurse will test the employee herself or himself, or will send to one of our testing sites for testing. And that again as well, transport is provided. So once we've identified the person, we're trying to make sure that that person is got less interaction with the general, you know, with the other colleagues. And from there, then the person would be tested, sent home for quarantine. And at this point, I would like to pause. I might be one of the few who has had few challenges, especially with the number of cases climbing, you know, rapidly since June, July, most specifically, is that you would find at times where people say, I stay in a one-room house with the family. How do I even quarantine? And we ensure that we do education and awareness when we send anyone for quarantine while waiting for results. Our EAP, which is one team I haven't not mentioned, we've got about 6 EAP practitioners. We immediately bring them on board, especially at the level of quarantine. It's not for each and every case, but for cases where we think that they might play a role, we immediately bring them on board to start with that support and mental support and psychological support and counseling while the person is waiting for, while the employee is waiting for results. And once results are out, that's where, if it's positive, all our positive employees, any employee test positive, EAP practitioner provide support. They will get a call from a nurse on a regular basis. They will get a call from EAP on a regular basis. We are in the process, I think we've just started, of having some sort of support group especially for the positive employees, because we've realized that a lot of them are anxious, they don't know what is happening. But the support groups, we try to do them per side, not inter-site. So per site with the employee, with the nurse and the EAP, and that is entirely voluntary. So the employees, we tell them about it, they're interested in it, they form part of it for the time while they're at home. Apologies, this still refers to 14 days. This slide, I think was done just before we changed to the 10 days. But that's on one side. Then on the other side is those who are negative, we ensure that they come back. Everybody who comes back who has been away from work because of tests, and whether positive or negative, when they come back, we ensure that you go through our fitness for work assessment. Just make sure that indeed you're still good to go back to work. And that is done by the occupational health nurses, the aides. So our nurses are up and about. For the positives, we'll immediately go into make sure that there's the decontamination assessment, and this assessment is done, contact tracing, and incident investigation. And of course, all our close contacts, anyone who's identified as a close contact out of a positive, we ensure if they can self-quarantine. If not, we try to speak to NICD around it to see if we can, where possible, we speak to the DOH local. Daily symptoms monitoring, test, if they're informed to test if they've got symptoms, and psychological support, again, it's very important. We've realized that actually it's one of the, because most of the people, when you send them for quarantine, anxiety kicks in. Anxiety, sets in, and those who are sent for isolation, anxiety sets in. So we have make sure that all our employees receive ongoing counseling and psychological support from the day they go on quarantine. In conclusion, mine was I'll keep it short. Is that in conclusion is that we aim on 3 things. First and foremost, in everything we do, we say once we have a person identified as a PUI, we think about that employee first. If it's quarantine, it must be quarantine. If it's isolation because it's positive, and hence we bring in the EAP. Out of that, we ensure that our leave policy covers for quarantine and for isolation. So for as long as an employee is able to, if we pick up the employee or employee is picked up by his or her own doctor, informs us, our leave policy allows special leave for the quarantine and isolation. The occupational health practitioners come in terms of the symptoms monitoring. Once we know that that employee is comfortable, that's when we now worry about colleagues. This is where the contact tracing comes in, decontamination assessment if there is any, and the investigation. And lastly, authorities. Then that's when once we can then say if there's anyone who needs to be reported or notified, and that's when the notifications come in. That's me in a nutshell in terms of what we're doing in the council. Just a quick one is that between June and July, we had about, in the entity that I am currently servicing, we had about just less than 200 cases between June and July. And as I speak to you today, we're sitting on about 97% recovery rate. And now when I say recovery rate, what we're talking about is employees who are back at work. We follow each and every employee in terms of the process that I've just shared with you. We ensure that they're fit to return to work. Only when we can certify that the person is fit to return to work, that's when we capture them as a recovery. Thank you very much.
Thank you very much. That was Dr. Mayahabo Seslagwe, who's focusing on the local government or municipal sector with regard to his experience there in terms of the management of persons under investigation. That's the PUIs for COVID-19. We have some time left. before we close our webinar today. And so I want to invite all 4 of our panelists just to consider some of the questions that they've been viewing in the Q&A section. There are still some questions there, as well as those have already been answered. And even those who've been answered, you could add additional comments there when you look at that. For yourself, Dr. Sislahwe, you'll probably be having questions popping up in the Q&A now, given your presentation. If you could just also have a look at that. So a quick reminder. So for all attendance certificates for this particular session, please, if you have queries, you can email HWS, that is HWS training at Wits Health .co.za. That is HWS training at witshealth.co.za. CPD related queries you can email to info@nih.ac.za, info@nih.ac.za, and I will share with you some of those slides again with regard to the some of the logistics and administration. So I'm going to ask our colleagues, our presenters, Dr. Malimela, Sister Siabelo, that's Dr. Kuzwayo and Dr. Sislahwe, just to raise their hand if they need to. If there's any particular question that they want to address that's in the Q&A section, or a comment they want to add, since you know, colleagues might have presented after you and there's an additional key burning point you want to raise. Should I perhaps ask you, Dr. Malimela, if you have got any sort of overarching comments on this whole question of the importance of managing persons under investigation, given that we are now at this particular juncture of dealing with this whole national epidemic within the global pandemic that we're facing. Should I perhaps just ask you for some comments from your side? Dr. Malimela, if you could unmute your microphone.
Thank you, Kev. Yeah. Yes, thank you, Ashraf. It's very, very important for everyone to understand that the public health principles remain. And we therefore need to urge that in cases where there's a need for contact tracing in the workplace, that must happen, because those 4 items are very important. You have a case, you isolate, you contact trace, and then you follow up. So that's part of the public health management measure for any infectious disease. I mean, for tuberculosis, this has been happening for over 138 years. We still don't have, an effective vaccine. For HIV, this has been happening for 40 years. So those measures are very, very critical. And one other question that I just want the panelists to understand here is that there is guidelines that direct how the setup in the workplace must be. And this involves appointment of the COVID-19 officer who's responsible, legally speaking, to guide the organization, coordinate with the doctors, the HR, and so on. Remember, we said this is a transdisciplinary issue, and there's a legal compliance that's required. And all these investigations, they are risk-based. As I said, the main issue about community transmission phase is not to stop the infection, because in any way it's going to happen. The issue there is to reduce the transmission wherever that is possible. So those are the actual fundamentals around this. So the COVID-19 officer must coordinate all that and make sure that when risk is being done, risk assessment is done, then appropriate quarantine will happen for those that are at higher risk, and then follow the whole process again. Identify, isolate, and then contact trace. And that should also reach even outside the organization.
Okay, well, thank you for that, Dr. Malimela. Maybe a quick follow-up question. in dealing with the persons under investigation, has TB as, you know, both a public health and an occupational health concern in any way factored into your own activities and support you provide and your systems you put in place?
Sorry, can you repeat? My line is not very good.
Yes. So the question is TB, both as a public health and an occupational health issue, in your dealing with the management of persons under investigation for COVID-19. Has that been a factor in your, you know, preparation and your systems in place to deal with the persons under investigation?
Correct. Remember, COVID-19 or SARS-CoV-2 has not replaced any existing medical conditions. So it's up to all the healthcare professionals to remember this. The TB is still there, HIV is still there. Like yesterday, I was looking at the viral suppression of people that we have on HIV. What is the suppression rate? Things like, so we still have, so genuinely we know that the impact of poor access to health facilities also had impact on TB. For instance, TB, you still have to go into the whole, you know, screening for TB, you know, even diagnostics around TB. So that cannot be suspended because we've got COVID. As we say now, coming through this, you know, flu season in South Africa, we must not forget that in the battery of tests, this is a chest condition. And also the fact that somebody's PUI, it does not necessarily mean it's definitely COVID alone. And we also know that those that have both active and past TB, they've got, you know, relatively speaking, worse outcomes. So we cannot take COVID to be the only diagnosis. That is a differential diagnosis. So that's the fundamentals in terms of the principles of medicine, how to really navigate the whole space. You realize in my presentation, I spoke about the health system, because the health system must not forget anything that's important for health. It must remain robust and responsive to deal with this. Diabetes is one of those, and so on and so on. So those are key issues.
Thank you for that, Dr. Malimela. So maybe if I could quickly move over to Sister Seabelo. If you could just unmute your microphone. Are there any specific overarching comments you want to make, given that you've heard your colleagues and their presentations as well? And then I want to put to you also the question of TB as a public health issue, given that you're in the healthcare setting, and as an occupational issue for the fellow employees whom you are supporting in your workplace.
Thank you, Ashraf. You know, my experience is when we work together, we implement the protocol as stated. We will be able to safeguard the health and safety of our employees. And we know health and safety, it also starts with the employee, and then the responsibility of managers also or the employer must always come first. And with the issue of TB, we know South Africa is burdened with tuberculosis. So we are not putting it aside. TB is also prevented. When we look at COVID, we look at it again with TB, because we've had that the preferred mask for the prevention of spread of COVID is the surgical mask. And that surgical mask is not effective in TB prevention. Hence, we emphasize the respirator. So we identified the high-risk areas for TB, and that's where the respirators are being used. Thank you.
Apologies for that, my microphone. Thank you very much for that, Sister Seabelo. Dr. Guzwayo, from your side, your sort of final overarching comments with regard to your input and your particular sector and what the key priorities are for that sector, including my questions with regard to TB. Dr. Kuzwayo?
Thank you very much. I think there's still a lot of challenges in our sector. It is important for all the role players and the stakeholders to really align in terms of what needs to be done, for them to continue to be vigilant, particularly as we have seen in China, that continuously. Once the international travel is allowed and that the possibility of importing cases is still there. So it is important to ensure that a lot of these changes continue to be a way of life. It is important to continue to have people adapting in new ways of life. And I've seen some of the questions that relate to people that may not be able to be tolerant of masks and people who may have asthma and people who may have serious problems with some of the odors. And at the moment, what the airlines are doing, they are trying to accommodate those people at the back. We still have a challenge in terms of social distancing when people are seated, which is something that is still there. But we also need to ensure that we're getting used to booking in advance, and so that people are able to complete and fill these questionnaires, the travel questionnaires, even before they come to the to the airport itself, and creating an environment of honesty remains a big challenge, because there's still going to be a lot of people who are not really going to be disclosing, and because they are eager to travel, they're eager to go there and there, and as you know, the screening procedures that we have are not really very high in terms of sensitivity and specificity, and so there's still going to be a lot of cases that may be missed. So it is important that individuals continue to really understand that they've got a duty also to protect themselves and to protect other people as well. A number of communicable diseases will continue to come. I think there was Zika virus before, and there's a lot of diseases that are going to be seen in our environment, and the collaborative process that already exists, which I mentioned earlier by the WHO, is really aimed at trying and assisting, particularly when it comes to those issues. Thank you.
Thank you for that, Dr. Kuzwayo. Dr. Seslagwe, there are some questions as well, and I want to remind my colleagues just to go to the Q&A, Dr. Malimela, Sister Sebelo, and Dr. Kuzwayo, to go to the question answer box at the bottom, and then just double click that in order to see questions that you may want to answer. There's a specific question for you, Dr. Seslagwe. It says from Moslala, and the question is to you, please clarify the type of transport that transport the PUI to the medical center. So if you could answer that question as well in the context of your comments now.
Thank you very much, Ashraf. Yes, I've seen that question. So the two things, first and foremost, colleagues, remember, according to legislative requirements, it's there that we need to, as an employer, it's responsible to provide that transport to minimize the risk of transmission, to the general public. So question in terms of what kind of a transport or vehicle should we have? With us, what we do is fortunate to say we have the likes of your Avanza. So however, we actually say any vehicle that you can be able to do social distancing, it's good enough. So ideally not a single cab type buggy. That not, we discourage that. We discourage that based on the risk assessment we did. However, we say even if it's a double cab, we can be able to set, we can be able to observe social distancing. We even going now a step further to say, hang on, we've learned one or two things from the Uber guys. you know, the Uber industry. You see, when you drive around, you'll see all the Ubers, or if you use Uber, they actually put almost like a plastic, you know,
It's
screen.
a barrier between
Yes.
the driver and the passenger.
Yeah, so we're actually looking at that to say, okay, can we actually have for dedicated transport? So as I said, we fortunate to more have a lot of Avanzas that we use as for day-to-day transporting of employees. We're actually looking at that to say, can we put a customized barrier that is, you know, it's removable easily? So in a nutshell, as long as any transport, any vehicle that you can be able to have that distance between the driver and the PUI.
Yeah, thank you for that, Doc. So to all of the panelists, there's a question that speaks to the high recovery rate as a result of some particular action that you can share. So Mokhogodi is asking, have you had any high recovery rate, and what would you ascribe that to in your experience? And it's, I will allow, we've got about 4 minutes left. I will allow anybody just, you know, to pitch in first on that particular question. Just unmute. I don't to ask, I don't know, maybe I should ask you, Dr. Malimela, first.
Thank you, Ashraf. I know this, I'm very, very careful on that, you know, answer on what we call recovery. As we say, this is quite early, and I'm 7 months old. So what we prefer to do is to make a distinction between de-isolation and recovery. And then our occupational health practitioners do that assessment. So unless somebody is examined and is found to have no residual impairment, we can't talk of recovery. And actually, there's a publication that came out, which was in the American Journal, that had a review of 100 cases. The sample size may be small. And out of that, 38% of the people, including the asymptomatic ones, were found to have evidence of myocardial involvement on a series. It's a recent study. So that's why that term of recovery needs to be carefully being assessed. And also we have seen, particularly amongst our healthcare workers, that return quite early because they were de-isolated and so on. Most of them reported to still have some fatigue. They still reported to have some bit of headache, and you say you can stay home, they say, but I mean, there's nothing I'm doing. I know I'm no more infectious. So that recovery needs a very strict criteria. I think for now is very grossly explained. I'll be very cautious to say recovery without physical examination by an OMP.
Thank you for that. Sister, there's a particular question directed at you coming from Tabile Mnisi. This is directed at Sister Lesego Seabelo. We appreciate your presentation. My question is, after your findings, do you send your clients to oh, it's jumped when somebody, okay. Do you send your clients, there we go. My question is, after your findings, do you send your clients to the ongoing counseling? And what about their families? Do they, by any chance, take them for testing to make sure that they're not infected? Sister Seabelo?
Thank you. One of the challenges that I raised was psychological support that is not adequate. And in going forward, I indicated that there's something that we need to look at, the mental well-being of employees, because currently that is not happening. So it needs attention, even for us OHS staff who are rendering the service. In fact, this service needs to be accessed by everybody, of which at the moment is so inadequate.
Right. And does that mean a review and a strengthening of the employee assistance program to also not just address the employees directly, but also to provide support to their immediate families?
That should also be looked at to say, if the EAP is looking at the employee, then how is that service extended to the family member? Because what is happening in the family will also have an impact in the workplace. Really, this have to be integrated.
Thank you very much for your response. We have now run out of time. I'm going to ask the panelist, that's the NIH panelist, as well as our presenters, just to ensure that they remain to continue to work on the open questions that we have there. I just want to remind the attendees of the administration that is relevant, as well as the importance of impacting in their workplace. So in order just to, before I move on, I just need to find my list of panelists. Okay, and then to share this particular set of slides. So I'm going to say thank you very much to our panelists from the NIH. That is Ms. Dikeledi Matuka, Ms. Anna Fourie, Ms. Moses Mokone, Dr. Odette Volming, Dr. Samantha Yalu, and Ms. Jeanette Manganye, who's also that is obviously also Dr. Tanusha Singh, who's also, and Jeanette Mangani is the head of our occupational hygiene section as well. So we've had colleagues from immunology, occupational hygiene, and occupational medicine. We say thank you very much for their contributions and their continued contribution to answering the questions there. And just to quickly then share and remind our participants, if I can just get this to go smoothly and without any interruption. So there we go. So we've had, and I might move on some of the slides. Our program, we've had the experience in mining by Dr. Jameson Malamela, who's from the Sibanye Stillwater experience that he shared. Dr. Malamela, thank you very much for your contributions. And then to Sister Lisejo Siabelo, who is at the Dr. George Mukari Academic Hospital. Thank you for sharing your experiences on the persons under investigations in the healthcare setting. And then to Dr. Kuzwayo for sharing his experiences in the aviation industry and the aviation sector. And then to Dr. Setslagwe, who's addressed the experiences in the local government and municipal sector. Thank you very much for that. And then as a quick reminder, if I could just go the other direction, for the presentations and videos and audio recordings and posters, you must go to the NIH's website. It is a zero-rated website by all of the mobile cell phone service providers and internet service provider as well. And that is www.nioh.ac.za. That's the website, www.nioh.ac.za. We do have the email address, which we recommend you write to. That is info@nioh.ac.za, and that might be CPD or other admin-related matters. For urgent matters, we have the hotline, and we have some of our colleagues there. There's not many of them, and so it needs to be urgent matters, not administrative matters, to 0800-212175, 0800-212175, and please follow the NIH on the Twitter handle that is @NIH_SA, @NIH_SA. And then it's important to be reminded for those who are qualifying and members of the accredited professional bodies, you will receive a link later on that will take you to the online CPD test, which you can do in order to secure the CPD attendance certificate for your professional body. And the bodies that are already accredited listed are listed there. We are working on some of the other accreditations. And finally, for those who require the attendance certificates, the email address that you need to direct your request to is hwstraining@witshealth.co.za. And on that particular point, I need to say thank you very much to everybody, and we look forward to seeing you on our next COVID-19 webinar presented by the National Institute for Occupational Health in a partnership with the Wits Health Consortium with the support of the Health and Welfare HWSETA. I'm now going to say goodbye and ask our colleagues who are online. The Q&A section is now closed. We are asking our colleagues only to answer the questions that are remaining. So thank you very much.